Okay, so these are your slides on postoperative care or nursing care. All right, so postoperative care is going to begin whenever a patient leaves the OR. So typically they leave the OR and they're going to go directly to the post-anesthesia care unit. Sometimes we call that the recovery unit. They may call it something a little bit different depending on the facility, and it's going to end when the patient has healed from surgery or when they're released from surgical care from the surgeon. It includes the post-anesthesia phase as well, which is that PACU. So that typically is going to be like supporting the patients during the recovery from that anesthesia. So remember, that's not always going to be general anesthesia. That can be the regional anesthesia, which could just be a local anesthetic. Typically, if they're going to be in a PACU post-op type care where they need recovery, they're going to have some sort of sedation or at least like a spinal anesthetic or something going on where they need supportive care. So most of the time when they're in, or not most of the time, when they're in a post-anesthesia care unit, we're really going to be worried about airway, breathing, circulation, and also those complications, pain control, nausea, and looking at any complications that can occur from the surgical procedure and or anesthesia from surgery. So pain management, preventing complications, and then a lot of educations, both in post-anesthesia care unit, which is really just kind of like the education of like what's happening right then and there, which is a lot of reorientation, and then reinforcing that education that has begun in the pre-op stage, in the post-op stage. That education we talked about pre-op, we just reinforce in that post-op stage. Okay, so the immediate post-op care. So the post-op anesthesia care unit, the nurse is going to receive that report from the OR nurse that we talked about. So you're, of course, going to get all that general information. What was the surgery that was performed? Kind of what was the background? Why did the patient need the surgery? What was their medical history for it? What surgery did we get? What's the patient history? What was the relevant history that we need to know? Is there any respiratory issue, cardiac issue, or any other issues that the PACU nurse and then the post-op people would need to know so that we could pass that on as well? What happened intraoperatively, and what would we need to know in the PACU for management? So any current physical, emotional, mental status of the patient that is pertinent for their care. And then for the PACU, for discharge, the patient is going to need to be stable with their vital signs. So that's going to mean heart rate, blood pressure, temperature. I was like, I don't know what vital signs are for a second. Respiratory rate, pulse ox as well. And then they need to have effective ventilation. So 9 times out of 10, this means that they are leaving completely without any airway. So every once in a while, you'll have a patient that's going to leave post-op care, and they are actually going to go to the floor on a ventilator. And those patients obviously are going to be admitted to ICU. So these are going to be patients that have had a more extensive surgical procedure. They may be somebody that's had like a CABG or something where they're going to be admitted to the intensive care unit themselves. The patients typically, though, are going to be easily arousable and much closer and are going to be alert and oriented to their baseline levels. Well, not alert to their baseline levels. Let me say that. Oriented to their baseline level and easily arousable to voice, but they can be still drowsy, but you would be able to arouse them to voice. And we do not see those complications. So their cardiac status and their respiratory status are going to be absent of complications. They may still be in a little bit of pain. They may be a little bit nausea, but they should not be actively vomiting, and their pain should be at a level that's manageable. And they should not be having like active hemorrhaging or anything like that going on, because that would be a sign that we would need to watch them more closely. If there's anything like that going on, they should not be that far away from the, the operating room at that point. So immediately post-op care, they will need their vitals monitored every 15 minutes minimum. They will have oxygen saturation levels monitored continuously with the pulse ox. We'll monitoring their level of consciousness pretty continuously, frequently, assessing their skin color and condition. We'll want to have to keep them warm. A lot of patients, even those that are not elderly or have issues with them, are going to come out feeling very, very cold in the PACU. If you think about the fact that, especially with general anesthesias, these patients are going to be, first of all, if you're sedated, everything slows down. But if you are under general anesthesia, they actually paralyze general anesthetic patients. And so everything is completely paralyzed, blood flow, or muscles completely paralyzed. So everything does feel very, very cold to these patients when they come out. So a lot of times we have warm blankets and they're very cold in there, so we have to keep the patients warm. Frequent assessments of any dressings, drainage tubes. Some of these patients come out with multiple tubes, so you have to watch those very closely. And you're looking for not only signs of excess bleeding, you're looking for signs of excess bleeding, but you're looking for signs of any abnormal drainage. And you're making sure that everything stays in place and is correct, and monitoring the IV fluids and keeping track of that, managing any pain, IV analgesics, and you're also managing any other side effects. Are there any allergies, any signs of allergies such as like urticaria, itching, redness, flushing? Do you see any nausea, vomiting, or any other complications that you might see, such as malignant hyperthermic signs? So airway is going to be your absolute most important thing. Remember, we've just had a patient that was potentially intubated, or at the very least, they had some level of sedation. Even patients that had local anesthetics typically have some sedation to, even if it's just a benzodiazepine for sedating them, for calming them down. They usually have some sedation. But respiratory assessment is going to be your most primary tool. You're going to assess the rate, death rhythm, pulse ox to monitor their oxygen, SpO2. You look at their use of accessory muscles and note that. You're going to assess their breath sounds, note any sputum production, if there's an ET tube in place, type and flow of oxygen. So for the nursing care, if there is, you're going to maintain the patient's airway suction as needed, provide any O2 as indicated. You're just going to titrate that as needed. Most patients will come in with some sort of supplemental oxygen, and they may leave without any, or they may leave with that greatly reduced. So it's just going to depend on each patient's individual status throughout. So a lot of patients still have a little bit of oxygen as they leave, but it needs to be just stable, so that they're just not like dropping down, and their respiratory effort and pattern needs to be stable. Patients need to be placed on their side unless it's contraindicated, because if they're sedated and they are not able to, they're going to be an aspiration precaution is really what I'm saying. So if they're sedated, you can place them on their side, and that's going to put them on less risk of aspirating. If you do have a patient that comes into the PACU with their ET tube in place, you want to take out, or any kind of airway, because I have had a few come in with just an oral airway that just keeps that airway open because they're very sedated. So that airway just keeps them from kind of having that collapse. So if they start having a gag reflex, you need to remove that as soon as that gag reflex returns, because then they can vomit. So as soon as that happens, that needs to be done. So circulation is obviously going to be extremely important, not only because it's just a very important thing, but also because they've just had a procedure that puts them at risk for hemorrhage. So there are times where something has been cut and it's going to be missed, because when you're in there doing a surgical procedure, there are times where there will be something cut, there may be a slow bleed or something that was cut that was completely missed in the surgical procedure, or something that inflammation maybe gets to and damages it and it is cut and you lose it, and it was missed, or it maybe increases. So we need to watch very closely for circulation issues. Also, because the patient is laying in bed because they just had a procedure which made their blood flow static, so they had venous stasis. We want to watch for blood clot formation, and we also want to watch for hemorrhage as well. So patient's going to be on continuous cardiac monitoring, so we can watch for any signs of dysrhythmias. We also want to watch their skin color. So you're going to be looking for increasing pallor. So paleness, you want to watch for cyanosis, so that blue undertone. Remember, that's going to start peripheral first because everything is going to move central, because our body compensates to protect our organs first. So you're going to see it in the fingers, toes, and lips, and oral mucosa first. And then once we start seeing it central, that means we've probably moved beyond early stages and we're seeing central cyanosis. That means we're probably pretty bad, right? You're going to monitor your fluid balance, which also, when we're talking surgical, that means most likely if we're seeing a small fluid balance, we didn't replace our fluid volume to replace our estimated blood loss, right? So that might be a sign of hemorrhage. And then neurovascular status of our extremities as well in here, and that could be because of fluid volume as well. So we want to promote our venous return to to prevent venous stasis. Typically, we're going to keep those SCDs on in recovery, monitor our extremities, make sure that we aren't seeing any signs of blood clots, pain in those extremities, make sure that we don't see the cyanosis, make sure that we don't have with signs of pulmonary embolism, where you would see the central cyanosis, chest pain, extreme shortness of breath. Monitoring for hemorrhage and hypovolemic shock, which is going to be an elevation in our blood pressure, decrease in elevation in our heart rate, decrease in our blood pressure, and diaphoresis is going to be our signs of hypovolemic shock and hemorrhage. So a little bit more about the hemorrhage, which is just going to be that excessive loss of blood from the circulatory system. It's going to be difficult to control. And hemorrhage can be both internal or external bleeding. So when you think about like a surgery, if you have, you have a big open wound. So internally, we've done our surgery. Say you've had a colon resection. So you could go internally and you resect your colon. You could have part of where you've resected your colon, something inside, say a vein on the colon itself. We could have cut into it and missed something, and that could be bleeding internally. Or as we were sewing up the patient, we could have something on their wound itself that is bleeding externally. So either one of those things could be bleeding internal or external. So we could also see blood draining from a wound. So the wound itself, so if we pulled open pulled up the gown and we were assessing the dressing on the wound, we could see that we have all this excessive drainage from the wound happening. And that would be pretty easy for us to say, okay, well, this is obviously a sign of where our, it's an external hemorrhage and this is where our bleeding is coming from. Or we could have an internal hemorrhage that was abdominal, and we would have to look a little bit harder, where we could see, well, the patient's pale, but I don't see any actual bleeding happening, where you would have to say, well, I see that their stomach, that there's a sign of maybe hemorrhage underneath their stomach, because you could see the bluer purple undertone of their stomach. And then when you were to touch on it, you could see that their stomach was becoming hard. because of the blood underneath it. So there are things that you can see for an internal hemorrhage as well. Or if they were to have a tube in place, you could see that a drain or a tube, depending on which one, you could see all of a sudden that they were putting out excessive drainage from an internal hemorrhage. So there are always ways to identify internal hemorrhages. It's just a little bit more complicated. There are other ways too, like to identify like arterial bleeding versus venous bleeding. Now internally, it's not necessarily going to be as easily identified, but externally it is a little bit easier to identify. So arterial bleeding, it's going to be rhythmic. It's going to be with the heart rate. So as the heart pumps, arterial blood is going to kind of, sounds weird to say, but it's like splurting out. So with heartbeats, the arterial blood is going to splurt out with the heartbeats, whereas venous blood is just kind of going to continuously flow out. And that's typical. When you think of something bleeding, venous blood is kind of how people typically bleed, whereas arterial blood is going to be, every once in a while you're going to see it bleed. Arterial blood typically tends to be more bright red, also, as venous blood seems to be a little bit of a darker color most of the times. And also with the hemorrhages classifications, it's kind of important. Really, primary and secondary are the most important for me to remember, or for you to remember for me, whereas primary just means it happens at the time of surgery. So as surgical procedure is happening, something gets cut or damaged during the surgical procedure. So primary hemorrhage is during the procedure itself, you have a hemorrhage. Secondary means after the procedure. So it's typically 24 hours after, something happens, usually as a result of like inflammation, wear or tear, and then a secondary hemorrhage occurs. Whereas intermediary really is like a shear, that's a hard word for me to say, a shear to like a vessel or something occurs. And it could be during the procedure. So like something shears against it. And then that vessel or something would get damaged, and then that is the cause of the bleeding. So it's not really related to anything that you're working on, but something else gets damaged in the process. So going back to the PACU, where we're looking for the monitoring for hypovolemic shock, where you see that severe blood loss and the fluids. So class 3 and class 4 hemorrhage is what hypovolemic shock is. That you're going to learn a lot more later on. So it's not like you don't need to remember it's class 3 or class 4, but I do want you to remember hypovolemic shock can occur due to extreme blood loss. And if it gets extreme enough, it's going to make the heart unable to pump enough blood to the body. So you lose enough blood loss, you have too little volume to pump through your body, and you're going to see the change in vital signs, which include tachycardia, extreme tachycardia, decreased blood pressure, cool, moist skin, and diaphoresis. So that's that sweating, cool, moist skin. You're going to see decreased concentrated urine output, at least less than 30 cc's an hour, typically less than 20. That's really the main thing. So your nursing care is to identify and control bleeding, fluid resuscitation, which means boluses, and treat the clinical signs and symptoms. I won't get too far into this because you haven't had fluid and electrolytes yet. So also during the PACU, you're going to look at the central nervous system. So you're going to monitor levels of consciousness. And remember, they can be drowsy, but they should be able to be arousable before we send them off. So you want them to stabilize. They can still be sleepy, but they have to be arousable. We want them to be more oriented before they leave. They need to be able to follow commands, we want to maintain their airway, we reorient the patient safely, and we want to provide for patient safety. And this is just, how can the nurse provide patient safety? So remember, if a patient comes in, they are sedated when they first start, and even though they're still waking up, by the time they leave, they're still going to have anesthesia in for a while. And even patients that go home, we can't send them home driving. They have to go home with the driver. So they're going to have anesthesia on board for a while. So it's important to reorient the patient frequently, and it's important to have somebody that is there to reorient them. It's important to have the stuff that they need by their side, the bed rails up, and it is important to make sure that the patient does not get up on their own. So pain management, it's a big deal. You don't want to like just jump on these patients and be like, hey, you have to have an opioid pain medicine immediately, because they don't always have to have an opioid. They do have some opioids still on board, usually from when they come into the PACU. So they aren't always just like in the most severe pain, but they typically do have pain when they come in because they did just go through a traumatic event. So it's really important to assess their pain levels. We're still going to start using the pain scale as soon as these patients are awake and able to do so, but we also want to use their nonverbal pain indicators as well. And we want to assess their response to the interventions, but we want to be cautious of medications. So, if they're like a 1 or a 2, we're not going to just shove some morphine into their veins. We're going to try, repositioning. We want to try to keep them on their sides, of course, as much as possible so that they're not aspirating if they're drowsy, but we can always try like pillows, changing positions, trying to get them comfortable. But we also don't want to wait till they're like at a 10 before we give pain medicine. So you need to just be very careful. You want to validate, accept whatever they say their pain medicine is, try repositioning, but before their pain level gets very severe, you're going to have pain orders for you, and you're going to use your pharmacological interventions available, but just do frequent assessments of the respiratory status, especially. For your older adults, you want to monitor them very carefully and frequently. They're going to have an increased risk of confusion and post-operative cognitive decline. So there are some older adults that when they go home, they will have a much longer recovery period where they even up to weeks where they'll have some decline in basically their cognitive decline, where they'll have confusion that lasts for a longer period afterwards, whereas a younger adult wouldn't have that. And they are at an increased likelihood of this, not only because of the fact that they have an increased likelihood of having dementia, but just because of the way that their body metabolizes anesthetics and things more slowly as well. So they're going to need more reorientation at the beginning, but there's also that increased risk for them to go home and have this. So it's something that they need to be aware of as well going into surgeries. And then if this happens, they need to be aware that this can continue for a few weeks, and it's something that is possible that it can occur. All right, so here is some post-op things. We're kind of getting into some meat and potatoes of what like happens. A big post-op once we get out of the PACU that we really are like focus on the floor once patients get on there. So atelectasis is kind of like that precursor to pneumonia, but it's bad in just itself because it is uncomfortable and not good for patients to have because it causes discomfort. So atelectasis really is just the collapse of alveoli in the lungs. So if patients do not take nice deep breaths, what happens is the cells, some of our alveoli release surfactant, which makes their cells nice and pliable, and they just kind of like expand really well. But if we do not take deep breaths like we're supposed to, they just kind of don't expand as well as they do, and then eventually they can collapse. So if a patient's hurting, they don't really, or they're just laying down and they're not used to, they just don't want to like expand their airway, they can eventually get to where their alveoli don't expand well, and then they can collapse, which we can start seeing in our assessment, where they have dyspnea, which is shortness of breath, tachypnea, which is that increased respiratory rate, or pleural pain, which is another word for that is pleurisy. So these are all going to be used interchangeably. If you don't know the terms, learn them. You can see diminished breath sounds, or even absent if the collapse is bad enough. Usually it's just diminished over the areas of collapse. The patient is not, they may be a little bit tired, they may feel, they feel uncomfortable, they just don't feel themselves because of this. And at times, especially with older people that already have respiratory issues, they may even need a little bit of oxygen for this as well. But usually it kind of puts them down and out, and it can lead to other issues, mainly pneumonia. So what we look for is the things to expand our airway. So anything that promotes expansion of your airway can prevent atelectasis. So prevent pain is a very nice, helpful thing for promoting the prevention of atelectasis. So if a patient's, if you prevent their pain, you can prevent atelectasis. So proper pain management, splinting for coughing is also another pain prevention. Deep breathing, so the turn cough deep breathing, the deep breathing part of that is for atelectasis because we take nice deep breaths. The incentive spirometer is the deep breathing. Up and about is going to help expand our airway, and then to raise the head of the bed helps expand our airway to keep pressure off of our airway as well. So expanding your airway is going to keep our airway open, and that's going to prevent these symptoms that we have, which can also prevent pneumonia. So talking more about pneumonia, so first of all, you want to prevent atelectasis to prevent pneumonia, and you want to prevent the gunk that gets in our lungs to prevent pneumonia. So pneumonia itself is an inflammation of the lungs caused by a microorganism. But you know what? It's actually not always caused by a microorganism. It's an inflammation, but we want to prevent any infection from happening. So once you get pneumonia, you're going to have this shortness of breath, that dyspnea, that tachypnea, and that chest pain that we had with atelectasis. But additionally, we may have that diminished or absent sound, but we also might start having crackles and wheezes, maybe even some rhonchi. We'll also have the signs of infection, the fever and the increased white blood cells that we have with fevers because we've now let an infection set up in our lungs. So with pneumonia, we want to prevent that by preventing those atelectasis, so turn, cough, deep breathe, incentive spirometer, pain control, get up, move around. All of those same things that we did to prevent atelectasis, we do to prevent pneumonia as well. So we prevent it first and foremost, but if we already have it, we need to treat it. So we have to prescribe the medications to treat it, which are typically it's bacteria, so it's antibiotics, but you can have other organisms. We want to increase fluids to thin out the secretions. We want to give oxygen as needed as well. Okay, so thrombophlebitis would be an inflammation of the vein with the formation of the blood clot. So this would be due to an injury of the vein due to external pressure behind the knees or venous pulling, secondary to immobility. So this would be causing a deep vein thrombosis. What you would see this happening most frequently would be in the lower calf, and you can see this in this picture here. So typically you're going to see this in the lower calf, and you're going to see this unilaterally. So it's just going to be on one side where you see it, and the patient's going to have pain on one side in the lower calf, and it's going to be swelling, so edema, erythema, which is redness, warmth, which is, so it's going to be warm to the touch, and it's over the affected area, which is almost always in the calf area for these patients. A lot of times you're going to measure the calf and the thigh circumference of that leg to see the difference in the measurements. So this is going to happen a lot of times for patients, or you're going to see this in patients that were immobile or they had risk factors for other reasons. We're not getting into the other reasons right now because you'll have that in another lessons. But for our post-op patients, because of the immobility and because of the surgical stasis that happened while they were in surgery, and because of the post-op immobility, they're going to be at increased risk of that blood pooling and therefore having the ability to form a blood clot. So there are, for surgical patients, most of the times they will have SCDs placed in surgery, and then there are VTE or DVT prophylaxis that must be put in place on all patients. So if a patient is not up and walking within the first 24 hours, you must make sure that they have some form of prophylaxis for DVT in place. You must monitor frequently for signs and symptoms of DVTs as well. So this nursing care for DVTs, this bed rest, I want you to just pretend that that's not on there because that no longer applies that every patient should be on bed rest. That is an old protocol and I really should take that off. Now you do want to go ahead and elevate them on an extremity on a pillow while they're in bed and administer any anticoagulants as prescribed. They will put them on a protocol. Typically it will be either a heparin or a low molecular weight heparin plus usually they're going to start them on warfarin in the hospital, but they may use something different depending on the facility's protocol as well. So our big deal for our clients is if they were to get a DVT, they could have a pulmonary embolism. So what happens is the DVT can travel into the lungs and cause obstruction of a pulmonary artery. And that typically is caused by something originating in the lower extremity and traveling to the lung. In about 10% of clients, this can cause sudden death for these clients. What happens is the patient will have, or the symptoms will cause sudden chest pain, severe dyspnea, and they will have absent breath sounds in the affected area, and then you will often see blood-tinged sputum or hemoptysis, and that's related to tissue destruction that's occurring because they're not getting blood flow to the area of the lungs that the blood clot is cutting off blood flow to. If you have a patient that is having these symptoms, severe symptoms, and having this sudden severe symptoms, you will often need to notify either the rapid response team, or if it's severe enough that the patient is not getting circulation or respirations through, you may even have to notify the code team and the primary provider ASAP. The patient will typically be bed rest with the head of bed elevated. High flow oxygen may be needed, and then they will be on a anticoagulant treatment and analgesics for pain control. So urinary retention is a pretty common post-op complication that we see, and it can be inability to empty the bladder completely or inability to void. So we'll have this excessive urinary accumulation because of decreased bladder tone. And this can be due to the anesthetics themselves, analgesics that are given, or even manipulation during the surgery or inflammation in the pelvic cavity. So we'll see that the patient's not able to void even though they may feel the urge to void. They may have even overflow incontinence. So even though they're not able to void, they may be incontinent. They may have suprapubic distension and discomfort, but yet they're still having oliguria, so they're not able to put anything out. So if a patient's not able to void within 8 hours post-op, you do need to notify the physicians. Typically, after 8 hours, the physicians will have you go ahead and put in a urinary catheter. Sometimes patients are able to void small amounts, but they're not able to empty their bladder very much. So you'll notice that they're voiding, but they're just not putting out enough output. So they'll have very small outputs within the 8 hours. So you may have to do urinary catheter, not urinary. I'm sorry, my brain just I had a brain fart. You may have to do a bladder scan to see how much is actually in the bladder to make sure it's not an issue with us not putting out enough urine before we actually put in a catheter to make sure that there's urine in the bladder. If they're putting out very small amounts, they'll do a bladder scan. They may put in a catheter, they may do a straight cath, they may encourage you to administer more oral or IV fluids, or they wouldn't administer oral, but to push oral fluids or IV fluids as ordered. One of the things that you're going to do early on is to increase ambulation, because that increasing of the ambulation is really going to help stimulate that bladder and help to decrease that or to increase that bladder tone and to help put back that natural tone in the bladder. So that is really just our best option for us to get that bladder tone back to where it is naturally. But we may end up having to put a catheter in. Typically when that happens, and if it's just related to like anesthetic, medicate, or the anesthetics that are on board, typically it's just going to be like an overnight situation, and we'll be able to like pull that out after a little bit. But sometimes if it's related to like opioids, things like that, you may like have to try an alternative medication or something of that matter. Post-op nausea and vomiting is a very common side effects. Not just the anesthetic, sometimes it's the opioid pain medication, sometimes it's because of the bowel stasis, because the bowels just aren't moving, or the hypoactive bowels. Sometimes it's an unpleasant wave-like sensation in the throat, epigastrium, or the abdomen. Sometimes patients just feel nauseated, but sometimes they will actually get to the point where they're vomiting. So patients just really feel really gross afterwards with it. Precipitating factors such as pain, anxiety, hypoactive bowel sounds can make it worse for patients. They may feel like they're just nauseated, or they may actually vomit. You may actually see patients that will give you signs that they're about to throw up, where you start seeing them start swallowing a lot. They may start doing the retching or the gagging before the vomiting actually starts. So you may be able to catch them and start doing the nursing care where you can catch them ahead of time and begin antiemetics, or even increasing the IV fluids can actually help with some patients if they have the proper fluid volume. If patients are having nausea, vomiting, you might want to progress their diet a little bit slower, because it may be because their bowels are more hypoactive. As their bowels wake up more, they're going to be able to tolerate it a bit better. Progress their diet as tolerated. Do not try to push that faster. Sometimes family members in the room will be like trying to push that, even though the patient is like not ready for it, because they think that they're like starving to death, even though it's only been like 8 hours or something, and you're like, they're going to be okay. They're having liquids, they have IV fluids. And then sometimes, especially with bowel surgeries, they'll need some NG decompression, or they'll be on suction for a while, because of the fact that those bowels are going to be a little bit slower to wake up. And if you stop the suction, they will start feeling a little bit nauseated, or they'll need that suction for just a little bit longer than others, because some just progress at a slower rate. So you just need to monitor that pretty closely, and you will, if a patient doesn't have anything for that, that is something that you would have to be contacting the physician for. But it's a very common side effect that we see, and typically we will have something available for it. So just be aware of it and watch for it and monitor for it. And I would say if you have a patient on opioids, monitor for it, especially with the first few doses. Even if the first dose was fine, monitor it with the first few doses as well, because sometimes the first dose is fine and they'll start getting it with the few doses afterwards as well. So abdominal distension can happen. They may have excessive flatulence within the intestines because of that peristalsis that happens as we move around the intestines, or because of the anesthesia slowing down the intestines. And then opioids, the more opioids that we have, the more the intestines can continue to feel the effects of the opioids. And then as a patient continues to lay in bed, so once again, get them up, walk them, move them. If a patient can walk, we need to get them up. The more they can walk and the more that they can get back to their normal activity, the better. So that's going to help with this. So assessing for that abdominal distension, it's going to feel distended. It's going to feel enlarged, taut abdomen. So as you push on abdomen, typically they're going to be soft, or they're not very large usually. So if you feel an abdomen that's kind of poking out, it's going to feel taut. It's going to feel firm. And it's typically, as you press on it, it's just going to feel it may feel uncomfortable for them. It doesn't always have to feel like super tender, but when you press on it, it's going to feel uncomfortable for them. And a lot of times it's going to be hyperactive because there's a lot of gas and air in the abdomen itself. So when you hear, normal active sounds, it's just going to kind of sound like bowel sounds. The bowels are moving around, whereas hyperactive, you're going to hear those frequent bowel sounds while it's distended as well. You're going to teach the patient, as they're increasing that diet, to avoid gas producing foods and fluids. That's going to help decrease those side effects that they're having with it. They may want to use some anti-flatulent medications. If you have a patient that they're just not able to get rid of that gas on their own, they may try a rectal tube, or even an enema can help get rid of some of that excess gas. Other things and I'm telling you, the best treatment is ambulation. So up and around and ambulating once again. Constipation, it's just constipation. So once again, this could be related to that reduced bowel movements during the surgery or immobility. It could be related to the medications. It could be related to the anesthesia, but things are just moving more slowly. It could be related to not taking in enough fluids. So we want to push fluids. We want to encourage increased fluid, fiber, ambulation, administer laxatives, stool softeners, enemas as ordered or as needed at home. But as the patient continues, ambulation, increase the fluid, fiber in their diet, and then the medications as needed. Another thing that happens because of the slowing down of the bowels, that can be the next step level. We can see the cessation of intestinal peristalsis because we just don't have that movement at all. And it can be, once again, because of the surgery, the anesthesia. It can be adding on the opioids. We can also have infection or even electrolyte imbalance. But what we would see with this is we're not having any stools. We don't have the bowel sounds. We will also start seeing the distension and abdominal cramping. With a patient, once we get to this point, we're really not going to be able to walk it out for them. The patient's going to have NPO and an NG tube for decompression because nothing's moving. So we're not able to give them food and walk it out. Now we're still going to have them up walking around NG tube for decompression until we can get those bowels to wake up and move around. Depending on the length of time, this might be the type of patient that may have to go on some TPN for a little bit. If this is ongoing, because they're not going to be able to get nutrients. But we would hope that we would be able to get their bowel stimulated, wake them up, and then we would be able to advance their diet slowly. But it would just kind of depend on their cause and our reasoning. But this is like constipation, but to the extreme level because the bowels are not moving at all at this point. Okay, so for post-op wound complications, as far as a wound infection goes, that is going to be invasion of an incision by a pathogen, and then that pathogen proliferates, or that just means like the pathogen expands, grows, there's more of it, resulting in inflammation, purulent drainage. So for the wound infection itself, when we were assessing that, we're going to look for local redness or erythema, edema, which is swelling, heat, and pain. So we're going to typically see with a wound itself, you're going to see redness and edema and heat and pain around the incision itself. But when we're teaching a patient or we're assessing it, we're going to look for that expanding further beyond the incision. So, and it gets worse, not better. So usually you'll say like it expands past a ½ inch past the incision itself. You're going to have the patient notify the physician. Or if we start seeing it expanding beyond a ½ inch past the incision, notify the physician. If you ever notice any purulent drainage, that is not normal. So that is a sign of an infection. It's normal to notice a little bit of serosanguinous drainage, even bleeding at first. It should be not frank. It should just be a little bit, and that's really just signs of hemorrhage versus non-hemorrhage. And then we're looking at our vital signs. You may see a slight increase in temperature, but anything over 100 degrees is a sign of an infection. We need to notify the physician. And if we see an elevation in our white blood cells, that's also a sign of infection that we would need to be concerned about infection as well. And once again, that redness, heat, edema, pain, we will see that at first because our body has an inflammatory process. That's its natural way that it goes in and it tries to repair and fix the damage that has occurred because we've cut into our skin. So it's trying to repair that. But it should be getting better as we repair and the wound heals. It should not be getting worse. So if we see that getting worse or expanding farther along, that's a sign that there's a potential infection. So that needs to be dealt with. And also, as we're dealing with these wounds, you know, there are things that we can do to prevent those wound infections from ever occurring. So of course, proper hand hygiene, using gloves, using the proper equipment, taking care of the wound, using the ordered, using sterile equipment, using the dressing change that is ordered, using contact precautions if there is a wound infection so it doesn't spread. If the wound has an irrigation as ordered, changing the dressing as ordered, and then administering any antibiotics and analgesics as ordered. Well, really, that's more for pain control than the actual wound infections, but they do hurt. So. Oh, and then post-op dressing change. It's important just to note that typically if you have a post-op dressing change that the surgeon's actually going to perform that very first dressing himself, typically it's going to be like 24 hours after the original one. And that's usually because he likes to come in and visualize and see that how the incision is doing himself. It's usually done as a sterile technique dressing. The physician will usually give exact orders for the type of dressing and the type of dressing change and the materials that he wants, including how he wants the dressing taped as well. So you should follow those exactly as ordered. And when you do, you'll assess the wound, and you'll assess the patient's response. You'll do teaching as well, and you'll usually teach them how to perform the dressing, or if the family, friend, caregiver, you'll do patient teaching or patient's family teaching at that time as well, and then you'll document everything. All right, so another post-op wound complication that can occur, and it is especially prevalent on abdominal wounds, open abdominal wounds, is wound dehiscence. So One or more layers of an incision will separate before it heals due to a strain on the suture line. So you want to assess your risk factors. So the most common, like I said, are going to be abdominal incisions, but this can actually occur in any kind of incision that you have. But abdominal are going to be the biggest risk factors, and it's just kind of because those are the wounds that are going to be at the most risk for strains. So abdominal incisions, especially if there's infections, any kind of distensions and strenuous cough are going to be at the largest risk. Elderly patients, those with anemia, poor nutrition, especially obese patients, those with diabetes, or those on steroids are going to be at higher risk as well. So you want to assess those risk factors. Patients will report typically feeling like the wound gave away or felt like it was tearing at the site of the incision. And when you look at the wound edges, they're gonna look like they're coming apart. So when we say, we're looking for whether they're intact or they're well approximated. When they're not well approximated, they're going to look like they're coming apart at the edges. So you see that they're not well approximated, or we're going to see like a lot more drainage, serrasanguinous drainage at the site that looks like we're starting to see the edges coming apart for signs that we may be starting to see potentially some dehiscence or risk of dehiscence at those wounds. So first of all, obviously, if you can prevent the dehiscence, looking at those risk factors, we want to identify those risks and really, take care, and of course you're going to do the teaching for this for all your patients, especially, abdominal wounds. You want to prevent any kind of straining as well, but especially you're going to see on these patients that are very high risk. They may even have like an abdominal binder in place to keep them from straining. If they're coughing, it'll keep them from having that ability to like strain those muscles with that as well. So they may have a binder in place, and you're going to identify if they have any things that are causing straining as well. And this can be stuff like the coughing, or if they have any vomiting, or if they're having issues with like constipation, making sure they're having a stool softener, making sure that they're able to use the restroom. They're not having any problems like that. So if you were to identify dehiscence, so you're starting to see those wounds give away, dehiscence is happening, you want to take your patient and make sure that you put their bed in low Fowler's position, and you take their knees, and their knees are bent. So you place your patient low Fowler's, knees are bent. You take that wound, and you put a sterile dressing over it, and you go ahead and you notify that primary healthcare provider immediately. So they may or may not need to come in and see them immediately. They may say, go ahead and just keep it covered, depending on how far the dehiscence is. If it's just, because sometimes a dehiscence may just be a small part of the wound, and they may say, okay, go ahead and cover the wound up with the dressing, tape it shut, and put a binder on the patient and keep them in this position and avoid straining, yada, yada, yada. So you may have a set of directions, or the physician may come in and, identify it and then give you a set of instructions, or they may want to go ahead and do a surgical procedure to make sure that they close it off. And it's really going to depend on risk factors, the patient's health. It's all going to be, individualized, because that's just how patient care is. But it's important that, you go ahead and set that patient in that low Fowler's, because that's going to reduce that strain on that abdomen. You put that sterile dressing on, low Fowler's, knees bent, dressing on, notify the physician, and then you start that care process right away, and get that process going. And so in the next slide, this is kind of like dehiscence, but we've took it a step deeper. So this is like the total dehiscence of the wound, to the point where now we are able to see protrusion of internal organs. So spilling of abdominal contents from the abdominal incisions as a result of dehiscence. So all the layers of the wound have dehisced. So, we've had every layer has come apart, and now we have visible protrusions. So you as the nurse, you go to look at the wound and everything has come apart and you're able to visualize. A lot of times what it is going to be is bowel that you're seeing come out of the wound. So the risk factors are the same. Most of your steps are going to be the same, so it's not super hard to memorize it. You're going to assess it, but you're going to look at it and you're going to see this visual protrusion is going to obviously be a little bit more. And you can see I use the same picture on both sides where you see at the top, you're not seeing the organs come out and it's just partial layers, and on the bottom you can see the actual evisceration. So when you go in it, low Fowler, the knees are bent. The difference is you need that sterile dressing. It needs to be moistened with sterile normal saline because you're putting it on an internal organ. So you're going to go ahead and cover it up. You put the patient in the low Fowlers, you bend their knees so we're not straining anymore. You're going to notify the primary health care provider immediately. Like this is at that point where, you know, the other one, we don't have organs protruding. So if you got stopped for 2 minutes, it's not life or death. Here, we're going to call that physician like, hey, we need, you know, you might even have another nurse sit with your patient for a while just to make sure that they're not moving around in their bed, because we're talking about internal organs being on the outside. And then you're going to call that physician immediately. And we're expecting that this may be a potential surgical emergent surgery needed. So we would be preparing this patient to potentially go into the surgery within the next half hour to an hour. So you would start getting charts together and getting everything ordered at the same time. So it would be a very fast moving process from there on out as well. And so here's just some possible nursing diagnoses that you would see. Of course, a patient coming back from surgery, they've had an incision of some sort, they're going to have acute pain. They're going to have an activity intolerance because of the physiological trauma that's occurred. So they're often going to be weak. But one of the best things that you can do for your patient post-operatively is get them up and moving as much as possible, because as you can see, it's going to help so many of those complications, and moving them around, as little as that seems like we're doing, prevents so many things, and it prevents those complications from occurring. And so a lot of our care centers around getting them back to those normal activities. They're coming in with this impaired skin integrity from their wounds, and we want to prevent all of those complications, those secondary complications from that impaired skin integrity that they already had. We want to prevent any complications from that. They're going to be at risk for injuries because of the anesthetics, the opioids that are already on board as well. And then we always are going to be at risk for ineffective management of their regimen that they have on board, and we want to prevent any complications from occurring. Remember, they're always going to be in a knowledge deficit. We started that post-op education for those complications in the pre-op, and so in this post-op, hopefully we are just reinforcing. We recognize those risks and we are preventing those risks as we move on. We recognize them, we're mitigating them, preventing them, and as they come, we're catching them early, preventing them, and if we happen to catch any, we are treating them early onset and keeping them from getting worse. All right, thank you.